Okay, so welcome to the resident room. This is our spot. This is our hangout suite. As you can see, there are some decorations going on. We have the nice Gamecock poster right there, the lights around the walls, the little poster pictures over there. We got a nice comfy couch. Of course, the whiteboard where we do all of our learning and jotting down information, quick little notes and things like that. And then our computers where we sit and chart review and review patients. We have a phone there where we have to call the ED, call nurses, answer pages, call patients, all the things that we do here from the resident room. It's a decent sized room for the number of residents that we have right now. However, next year we're gonna essentially double, so we're gonna need a bigger room. And so we're on the 7th floor of the hospital right now, but they're actually constructing a brand new 10th floor. Right now the hospital goes to 9 floors, and the 10th floor is just for storage. So right now they're cleaning out the 10th floor, and they're gonna make that an entirely new hospital floor where they're gonna actually have patient beds, and then the residents are gonna have a large room to work out of. So I'm excited about that. That is set to not launch, but it's set to open at the end of this academic year, which the residency and medical academic year goes from July 1st all the way to June, the end of June. So our new academic year starts July 1st. So all of the medical school students that are graduating are gonna start residency July 1st, and then all of the residents are gonna go to the next level of residency. So I will be stepping into my 3rd year of residency. We'll have a new intern class come in, and essentially as a 3rd year resident, I'll be the senior resident. So I'll be supervising the 2nd and 1st year residents and taking on a new role that is, I don't know what that's gonna look like yet, but it's exciting to know that I'll be starting my 3rd year of residency. It feels like I just started not too long ago. But yeah, I'm excited about that. And tonight I am working nights. So I've been on nights the entire week. So tonight I'm working nights. I'm by myself tonight. I don't have an intern with me. Usually I have one intern with me overnight, and we sort of handle admissions and tackle calls and rapid responses and things like that. But tonight it's just me. So I'm gonna be holding down the fort tonight. And that's why I'm able to actually use this room as a place to do this video. Normally there's people in here, and so I usually don't record a whole lot because I don't want to distract anyone. And I just don't want it to be weird. Some people don't like to be on camera. So got the room to myself. I can do what I want tonight. So I will be updating you guys with anything that comes up, anything that happens tonight. You already got a little bit of a tour of what this room looks like, and I'll be hanging out in here all night tonight. I'm fully flipped, meaning that I am completely nocturnal right now. My nights are my days, and my days are my nights. So I'm actually sleeping from usually 7 a.m. when I get home to about 4 p.m. when I wake up, shower, and get ready to start the night. So it is now 6:36, so I'm about an hour into my shift, a little over an hour. So I'm fully flipped. I'm awake. It feels like I just woke up, and I did just wake up, so. Yeah, it's weird working nights because everything is like completely distorted. Like my sense of time is almost non-existent. Honestly, I have to look at my watch every day to see what day it is, because I'm like, when you work overnight, you know, the new day, you're used to going to sleep and waking up and it's a new day. You know, it's Monday, oh, now it's Tuesday, oh, now it's Wednesday. When you work overnight, your Monday blends into Tuesday and your Tuesday blends into Wednesday. So you actually start shift Tuesday, but you leave on Wednesday, and then you start your next shift Wednesday, and then it goes into Thursday. So it's like, it's hard to keep up with the days. But As far as my sleep schedule's adjusted appropriately. It's just a matter of keeping up with what day it is. So that's my biggest challenge. And just keeping up with little things that I'm usually taking care of during the week and during the days like that I'm like a little off on. But other than that, nights it's been nice. I'm enjoying it. A lot of stuff happens overnight with patients. And so I feel like being the only person on tonight, it couldn't get a little interesting. But we'll see. I'm gonna get ready to start chart reviewing to kind of look over my list and see what I'm managing tonight and prepare to start admissions because those will be coming in any minute now. So I'll update you guys shortly. All right, so I just got my first admission. Sorry about the weird angle change. I couldn't find a better way to set up my phone and I left my holder on that side so I can do my actual update. But I just got an admission, so I wanted to show you guys what the process of doing this admission looks like. So the first thing is the admission comes in, they text my phone with the ED bed number, and the bed number is associated with a certain zone in the ED. So I just have to call that zone and get signed out from the ED doctor. But I did some chart review and I just kind of looked at what the patient is coming in for. So now I get signed out from the ED doctor with some more information. Okay, so this patient clearly has a UTI and they want to rule out pyelonephritis. Pyelonephritis is basically where you get an infection of your kidney and inflammation and excuse me. It usually happens when you have a UTI that has ascended from the lower urinary tract, which is like the bladder, and it goes up the ureters, which are the two straws that come out of the kidney to drain urine. And so when you have an infection that climbs up from the bladder and goes into the kidneys, they call that pyelonephritis, because then the kidney is now showing signs and evidence of damage and infection. And that can be really bad because the bacteria can get into the bloodstream and cause you to become septic. People get really sick and it's really painful. They are miserable with pyelonephritis. They get nausea, vomiting, they can't eat, they're in pain. And of course they're at risk of the bacteria spreading into the bloodstream. So this is definitely meeting criteria for admission. And I asked if they got a CT scan because the CT scan helps us to see if there's any evidence of inflammation or infection in the kidneys. You can't really tell that from the urine alone. Sometimes you can tell that there's some evidence of inflammation, some evidence of bacteria, but it does not fully confirm the diagnosis of pyelonephritis. So I'll need to put in a CT scan for this lady, make sure she's not septic, see how much pain she's in, admit her, start her on antibiotics, and go from there. Pretty straightforward admission. This is sort of what we call a bread and butter admission, meaning that they're coming in with this problem that you see all the time, and usually it's pretty straightforward. So that was my first admission. The next one will be coming up soon. I just had to show y'all what today looks like because I love the rain, and to me this is a beautiful day. Yeah, I'm a little weird like that, but look at this. This looks incredible. I love a nice rainy day. Yeah, I'm on the way to do my admission. I had to stop and show you how beautiful today looks to me. So admission number 2 is coming in. It looks like another kidney problem. I guess that's the theme of the night. Relatively young. I don't have much information right now. It just says kidney cyst. The ED doctor has not put in any notes yet. She literally just got here probably 5 minutes ago. So we'll see. I'm gonna call them now.
$39 is pyelonephritis and renal abscess. Abdominal and back pain for 5 days, subjective fever, some foul-smelling urine, had a white count of 15, bilateral pyelo on a CT.
All right, I'll come down shortly and see her.
Yeah, appreciate it. Thanks.
All right. well. Another pyelonephritis. That is the theme of the night tonight. So I'll probably talk about UTIs in a little while here once I go see this patient, but man, this sounds pretty intense. Bilateral pyelonephritis. That's basically on both sides of the kidney. There's both kidneys are infected, and she has a white blood cell count of 14. That's pretty high. And her heart rate's 104, her respiratory rate's 20, her temperature is 99. We have a source of infection. She meets criteria for sepsis, so she's sick. I'll go see how she looks. She may not be having a whole lot of symptoms. She's really young, so she's got a lot of reserve. I don't see any other medical problems in her chart, so I expect her to be otherwise healthy. Just unfortunately, she's got this kidney infection. I'll have to get a lot of the information from her when I get down there. But yeah, I mean, pretty much we would treat this the same way. The only difference is since she has an abscess in her kidney, depending on how big it is, I may need to consult interventional radiology or IR to see if they can drain this abscess. That's pretty much what interventional radiology does. They are specialized radiologists that do procedures. They use a minimally invasive technique where they use these tools to sort of get to the abscesses and things like that inside of the body cavity. But sometimes either it's not big enough or the abscess is complex and they call it loculated, meaning that it's just gunky and there's several pockets inside of it that just may not be appropriate for draining. So in that case, it's just IV antibiotics and supportive care, basically, until the infection gets smaller. I don't see a CT scan in the chart. Oh, they brought the CD, it looks like. So I'll review the CT scan and see how big this thing is and what we need to do from there. So this is my patient with the kidney abscess. This is a CT scan, and the way we're going to look at this is as if this patient is standing directly in front of us and they are facing us. So what looks like the right side is actually the left side of the person's body, and what looks like the left side is actually the right side, because they're going to be facing us. So going off of this view here, this is the spleen, this is the liver, these are the kidneys, this is the spinal column, the vertebrae, these are the paraspinal muscles, and this is a piece of colon, that's a piece of colon, and then as you go down, you have hips, left and right hips, and then the iliac bones there, and then the rest of that is more colon. So I'm gonna try my best to not make you guys dizzy, but so as I'm scrolling, we're moving through this person's body, and if you pay attention to the left kidney, if you look in this view, you'll see that most of the kidneys are equally contrasted. So they put contrast into the arteries, and the contrast goes into the tissue of the kidneys. So these kidneys are actually relatively bright compared to the spleen, the liver, the bones, the muscles. The kidneys look relatively bright. So this helps us to see the tissue a little better. And as we scroll through, you'll see that the left kidney starts to get gray towards the top. And when I say gray, I just mean that the rest of the kidney is not as contrasted. I mean, the rest of this part of the kidney is not as contrasted as the rest of the kidney. And that's because there's something preventing the dye from getting into that kidney. And what is that something? The abscess. And as we continue, I'm actually coming back through. And as we stop here, you'll see there's little pockets inside of this abscess. That is the loculation. Those are loculations. So there's no clear place to stick a drain in and pull any fluid out or pus. That's probably what's in there. but we'll have to consult IR for them to make that decision. But just based off of this CT scan, maybe not.